Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Hi, Paul.
Hi, Matt. How are you?
I'm excited to recap this discussion we had with Dr. Kittleson on cardiac amyloidosis on the podcast and bring the viewers our favorite pearls. So, Paul, can you tell me, amyloidosis, super rare, and if I'm admitting someone with HFpEF or seeing someone with HFpEF, I shouldn't even think about this.
Yeah, this great. I love that we're back to this teaching style, Matt. So great point. I think probably the major takeaway point from this episode is the fact that amyloidosis is probably far more prevalent than we actually recognize. But every article that you read says that this is a rare diagnosis. But Dr. Kittleson's talking about, well, 1 in 8 patients with HFpEF in one case series actually had evidence of amyloidosis, or 1 in 8 patients who went through aortic valve replacement actually had evidence of amyloidosis as well. So it's probably considered rare because we just haven't diagnosed enough of it, but it's probably been around for a long time. We just don't think of it as much when we probably should be thinking of it more often for patients with HFpEF specifically.
And along these lines, she has a pet peeve that I think is helpful. So when you see an echo and it says left ventricular hypertrophy, she says, how do you know it's hypertrophy? Because that's, you would need to really do a biopsy to say that the muscle fibers are hypertrophy. You should say increased wall thickness, because you don't know if it's thickened because it's hypertrophy or it's thickened because there's an infiltrative process like an amyloidosis going on. So don't get on her bad side, because that's one of the Kittleson rules that, you should say LV thickness, increased thickness, not hypertrophy. Dr. Deb Gorth made a great figure helping us remember some of the features, because the two main types of amyloidosis, as far as the cardiac amyloidosis go, there's the AL amyloidosis and there's this transthyretin amyloidosis, which we call TTR. So what are the clinical features that people should look out for?
We talked about this before, where patients who present with bilateral carpal tunnel syndrome who especially have no business having it. So we're talking, if someone presents with new carpal tunnel syndrome at 60 years of age, that's weird. You can see it in certain rare circumstances in younger patients, but otherwise that should raise the hackles in the back of your neck. The biceps tendon rupture, the classic kind of Popeye arm, should prompt that in the right clinical context, or even trigger figure to some extent. And then the light chain is sort of what I think of as the more classic kind of board questions for amyloidosis, like the macroglossia, the periorbital purpura, the easy bruising, the frothy foamy urine that might indicate proteinuria. And then overlapping between those two in this gorgeous figure is this polyneuropathy and autonomic dysfunction. And this can be a feature of either of these things. But there is a difference in terms of urgency of referral and evaluation depending on what you suspect.
So basically, if someone has increased ventricular wall thickness on an echo and they have one of these other red flags, then you should think about the diagnosis of amyloidosis. And the diagnosis is actually easier than you might think, like once you've actually thought to look for it, because you can check for light chain. So you get it SPEP, UPEP, immunofixation electrophoresis, and serum-free light chains, which are all tests that I think most internists order those from time to time if you're thinking about nephrotic syndrome, things like that. So if those tests are positive, then you may have found a case of AL amyloidosis. That is a bad prognosis, and you really need to get that person hooked up with hematology right away for bone marrow biopsy to confirm the diagnosis. And then, Paul, you told me you order a lot of PIP scans now, so we should talk about these technetium pyrophosphate scans.
Can't get enough of it, Matt. Yeah, radiologists love me. So yeah, when you're going down your algorithm, so you do the serologies that you discussed, which we should have some comfort with. And if the serologies are negative and you're not suspecting AL amyloidosis, the next thing you would worry about was this TTR amyloidosis, and that is diagnosed with this technetium pyrophosphate scintigraphy, which I'm not going to try to say more than one time. And if that is negative, then you start digging around for other causes. But if you have the negative light chains but a positive test, then that actually meets criteria for the TTR amyloidosis, and that you don't even necessarily need a tissue biopsy for that. So it's a really neat test to kind of fast track on the way to a diagnosis to kind of help figure your patient out. So it's not a test I had any familiarity with before actually going through this episode.
You look to see if the heart lights up more than the bones, then that's a positive test, and that's concerning for that they have this TTR cardiac amyloidosis. If they do have that, there's a drug called tafamidis, which is very expensive. Famously, it's a pill that's taken, and if patients can get it, it does have improved cardiovascular outcomes, and it's basically a stabilizer of the TTR amyloid fibrils. So that is the treatment algorithm. And Paul, as internists, we're probably not going to be prescribing tafamidis, but we might be prescribing guideline-directed medical therapy, GDMT, for heart failure, do we have to be careful with it? Because I like to just go wild with my GDMT when I'm treating heart failure. Should I be aggressive in amyloidosis?
Personally, pat myself on the back. I made a great joke about the major side effect of tafamidis being poverty. So let's just pause and enjoy that as it goes past. But to your point, Matt, if you're chasing down this guideline-directed medical therapy that we're all fairly used to, you should know about these patients in particular. They actually are very sensitive to volume shifts. And so Dr. Kittleson even talks about, you might even think about amyloidosis in the patient for whom you start on a low-dose vasodilator for just even bread and butter hypertension, and they just do not tolerate it, and they feel lightheaded and dizzy. So these are patients where you have to be a little bit cautious about your vasodilation, a little bit cautious about your diuresis, because they're very sensitive to that. And you can actually make them feel much, much worse if you're not careful with what you're doing, remembering the pathophysiology of what you're dealing with.
Yeah, and that could also, if you're seeing someone with heart failure and they're having these wild responses to diuretics or just, vasodilator therapy, then again, you might think about, could there be amyloidosis going on here more than just like your run-of-the-mill HFpEF or HFrEF? So yeah, lots to think about. Of course, our guest, Dr. Kittleson, is amazing. This was a very fun episode. We couldn't touch on all the pearls on this short video. So click on the link in the transcript if you would like to hear our full interview, or you can also find it on YouTube if you wanted to watch the full interview. And with all that, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Curbsiders. And as always, I remain Dr. Pal Nelson Williams. Thank you and goodbye.